connect. And today we are back with the webinar, which is sponsored by Foxy AIEC committee. And the topic for today's presentation is all about Placenta, West Zone, Maharashtra. And let me introduce MOCs for today's webinar, Dr. Rashmi Kahar and Dr. Monica Umbardand. So, Dr. Rashmi Kharodkar Kahar, ma'am is consultant in Amravati, Maharashtra. Ma'am is chairperson of AMOX High Risk Pregnancy Committee and organizing secretary of AMOX 2020. And ma'am is also joint secretary of Isobar Vidarbha and West Zone coordinator of Foxy Breast Disease Committee. And let me also introduce Dr. Monica Umbardand.
Okay.
Ma'am is consultant obstetrician and gynecologist in Mangalya Nursing Home and Atharva Fertility Center and PAC Committee chairperson of AMOX 22-24 and website coordinator for AMOX since 2008.
That should be enough. That should be enough. Don't read everything.
Okay, ma'am. So I hand over the session to Dr. Monica, ma'am. Thank you, ma'am.
Thank you so much for the kind words of introduction. We welcome you to the webinar on all about placenta. This webinar has been organized by under the guidance of Dr. Varsha Baste, madam, and it is organized by the Foxy IAEC committee. I would now like to introduce Dr. Varsha, ma'am. She is the convener for the program, and she's a practicing gynecologist in Nashik since the last 30 years, and she's also the director of Maternity Hospital Pushpa Fertility Center. She is the CEO and founder of Cell Gen Anti-Aging Stem Cell Center. She also has the first ICSI PGD baby born in North Maharashtra, and she has been the past president of Nashik OBGY Society. I also take honor to introduce the other coordinators for the program, Dr. Pratibha Singh, madam, and Dr. Sashibala Bhosle. Can we have the series? Dr. Pratibha Singh, madam, is a consultant laparoscopic and gynecologist. She's also an IVF consultant practicing in Bhagalpur. She's a national coordinator for IAEC Committee Foxy 21-22. She has been the president of the Bhagalpur Menopause Society, and she has many academic accolades to her credit.
Thank you.
Dr. Bala Bhosle is a president of the Gwalior OBGY Society for the current year. She is a consultant gynecologist in Public Health Department in the Family Welfare of MP government. She has been working in the public health and family welfare from the last 35 years. She's also the West Zone coordinator for the Breast Committee Foxy and member of IAEC Committee Foxy. I welcome Varsha ma'am to please introduce the chief guest.
Thank you, dear all, for thank you, Monica, for your kind introduction. And on behalf of Foxy International Academic Exchange Committee, I welcome all the esteemed galaxy of faculties. They have come all over from India, and I am really thankful for sparing your time. And we have galaxy of speakers, Dr. Hemant Deshpande, Dr. Gangadhar Sahu, Gaurav Mandrukar, Dr. Kuldeep Singh, and today, along with the delegates, I am also going to listen and enjoy the deliberations. I am really thankful to our chief guest, Dr. Pardeshi sir, who is the president of AMOX, and he is such a warm person. He's such a nice person, very, very affectionate and grounded, always says, yes, madam. Yes, I'm there, and he will send his CV, photo, everything. So no need of asking anything again. Dr. Rajendra Singh Pardeshi he is the president of AMOG, and he was faculty in AOCOG, also in Bangkok. He has presented 28 papers nationally and internationally, and 7-time best paper awardee. He was the VP of AMOG and also VP of Foxy, and now president of AMOG. We have witnessed the fantabulous conference of AMOGs was conducted under his leadership, and the Foxy VP elect Foxy, Dr. Ajay Mane sir, his what is a right hand. And really, we are so overwhelmed with the so much of academic feast in the AMOGs Aurangabad, and everybody enjoyed. The cultural night also was fantabulous. So I'm really happy, Dr. Pardeshi sir, for you being here and gracing this occasion. And I'm also thankful to Dr. Ajay Mane sir, and we have other guest of honor, my dear friend, Dr. Sneha Bhuya, who has done so much of work in breast committee that nobody can imagine a person like her who is having so much of busy practice, obstetric practice, but she really is very hardworking, very affectionate, very down to earth person. And another guest of honor, the budding Dr. Charulata Bapaye, who is also there. She was asking me, how come you have made me this guest of honor? But I thought that she's a young person and she's along with Dr. Sneha Buyar, who is already the chairperson of breast committee, and Charulata Bapaye is the president, chairperson elect of breast committee. So I thought I should combine and I should invite both of them, and they have obliged. Thank you so much. So over to you, Dr. Pardeshi sir, to give the pearl of wisdom, to give us some advice and address. Thank you so much.
Thank you, Dr. Varsha. Good evening, everybody. Respected Dr. Shanta Kumar, Dr. Madhuri Patel, Dr. Bipan Pandit, and respected Dr. Hara Patnaik. He is a messenger from Puri, means Lord Jagannatha. Dr. Ajay Mane, Dr. Sneha Buyar, Dr. Charulata Bapaye, Pratibha Singh, Dr. Shashibala Bhosle, and MOC. Not only they are MOCs, they are our ever active amongst chairperson, Dr. Rashmi Kahar, Dr. Ashwini, Dr. Monica Umbardhan. Placenta is the most responsible entity, I think, throughout ANC and PNC period. Even PNC period also, if placental problems are there, we may face many problems. And hence we have to take care of placenta. Abnormalities in the placenta and placental function may increase it also, and placenta still a major cause of maternal mortality. And if we forget or if we neglect to take care of this, it will get problems. This webinar is full of topics on placenta only, and with the eminent speakers like teachers, Ms. Hardcore teacher, Dr. Gangadhar Sahu also, Kuldeep Singh, and with the all esteemed chairpersons, I think this will be a nice webinar, fantastic webinar on practical topics. I congratulate Dr. Varsha Baste again for organizing such a practical webinar, and also for her future journey and every success in her future endeavors in Foxy. With this, even I congratulate to Dr. Sneha Buyar also, and wishing to see Sneha Buyar and Shashibala Bhosle for their future endeavor in Foxy. Wishing every success to this webinar. Thank you so much. Thank you,
sir.
Thank you, sir.
Over to Varsha.
Good evening and happy Navratri to all of you. And I'm really very happy to be the part of this webinar. And first of all, I would like to give my regards to all stalwarts who have joined today, and my special regards to our chief guest, Dr. Rajan Singh Pardesi sir, who is so down to earth, simple and easily approachable person. So thank you, sir, for your valuable presence. And now it's my proud privilege to welcome another well-wisher of mine. He had visited Bhagalpur n number of times, and again he is going to visit us in November, Dr. H.P. Patnaik sir. So welcome, sir. And I know he needs no introduction. He's a well-known personality in Foxy. He is past Vice President Foxy and past President Indian Menopause Society. And at present, he is Secretary General, Society of Vaginal Surgeons of India, which has been recently formed. So I would like to welcome you, sir, on this forum. And we need your pearls of wisdom and blessings for us. So over to you, sir.
Thank you.
Hara sir, we are really overwhelmed. You have raised the standard of this webinar just by your mere presence.
No.
You always encourage us. And thank you so much for gracing this occasion.
Dr. Vasta, it is very humble of you to speak such words for me. Thank you very much. But I really feel privileged to be here amongst you. And I really feel happy to see The giants over here, Dr. Hemant Deshpande, Dr. Kuldeep Singh, and Dr. Gaurav Bandrupkar, my friend and my teacher, Dr. Gangadhar Sahu. These four stalwarts will be speaking. Gaurav first on placentation, abnormal placentation by dear friend Dr. Hemant Deshpande, and Abruptio placentae by Sir Gangadhar Sir, and finally Dr. Kuldeep, the giant of ultrasonography. We love to hear him always. Kuldeep, great to see you again, and we'll be meeting you in Bhubaneswar on 9th, I hope. And what I want to say that International Academic Exchange Committee with Barsa Baste as the chairman has done wonders. And we get the information in all social media and everything, including your trip to Istanbul and Turkey. Well, Ajay, don't feel bad because you are there already in the group. You will be going to Turkey with Dr. Barsa Baste and great friend Dr. Rajendra Singh Pardesi, the chief guest of the evening. A great friend, really speaking. The president of AMAX is a very down-to-earth person and a very lovable friend. And Dr. Sasiwala, Dr. Bisal, Dr. Pratibha, thank you for introducing me. Dr. Sandhya, Dr. Sneha, big future for both of you, great ladies in Foxy, in your future endeavors, rightly told by Dr. Rajendra Pardesi. Without wasting time, I give all my best wishes to this excellent webinar which is going to happen from today with the giants. Best wishes and all the best. Thank you very much.
Thank you, sir.
Thank you, Dr. Rao, sir.
Over to Dr. Shashibala Bhosle, madam.
Yeah. Again, I'm so overwhelmed to be with you, sir, in the august company of all stars, the pillars of Foxy. So as Vash has already said, I have got the honor of introducing Dr. Ajay Mane, sir. There are only two words to describe him: dedicated and devoted, and we are safe when he's around. So Ajay Mane, sir, to have a formal introduction,
Yes.
member.
No, madam, we can skip that. We can skip that.
So Ajay Mane, sir, is enough introduction for all of us.
Thank you.
Welcome, sir. And I would like you to address the August gathering.
Yeah, thank
Please,
you. Thank you.
Over to you.
Thank you. Respected Rajendra Singh Pardesi, sir. And see, I can see all my teachers here. Hemant Deshpande, sir, Gangadhar Sahu, sir, then my Sneha ma'am, Varsha ma'am, and Hara, sir. So all seniors. And this is very great webinar after so long time. So best luck for this webinar. And best luck to Varsha ma'am, Sneha ma'am, and Shashiwala ma'am for their endeavor. And the great teachers will be speaking today: Sahu sir, Hemant sir, Kuldeep bhai, and Gorak Bandhu. Gorak Bandhu is not seen. He is having some problem in joining. Yeah.
I could see.
So
No,
best luck.
Yes.
For best luck for today's webinar, and it will be covering all about the placenta. Thank you for inviting me, and best luck for the webinar.
Thank you, Dr. Ajay Mane, sir.
Thank
Thank
you,
you. You are the voice of AMAX. Thank you so much. And the president, vice president elect of West Zone. So we congratulate you for the next tenure and thank you for gracing this occasion.
Thank you.
Over to you, Shashibala.
So our next guest of honor is again a very versatile personality who is so sincere, working wonderfully in our Foxy, Dr. Sneha Bhuyar, Chairperson Breast Committee, Foxy. And I would like to wish her all luck for her future endeavors. She is, she has a vast CV. She has been doing wonderful work and she has claimed so many awards and she has organized so many conferences. So with this, I request Sneha.
Thank you, Pratibha.
To share your views and give us blessings.
Thank you, Pratibha, for that wonderful introduction. Very good evening, respected President Foxy, Dr. Shantakumari, Secretary General Dr. Madhuri Patel, Vice President in charge of this committee, Dr. Bipin Pandey, all the esteemed faculties, respected Dr. Professor Gangadhar Sahu, Dr. Gorak Mandrupkar, Dr. Hemant Deshpande, and all the esteemed faculties, panelists, chairperson, a guest of honor with me, Dr. Hara Patnaik sir, Dr. Ajay Mane, my dear friend, Dr. Charulata Vape. and of course all the attendees whom we are coming in between. I just wish a very good evening to all of you. Hearty congratulations to you, Varsha, for this wonderfully designed program, right from placentation to localization and separation. Everything is covered, and I'm sure who else than these stalwarts can do justice with this topic. And of course, Dr. Kuldeep Singh, who actually takes us to along with him and demonstrates everything. So this is going to be very, very helpful to everyone. Once again, I thank you, all of you, the Master of Ceremonies, Dr. Pratibha, Dr. Shashibala, Dr. Monica, Rashmi, and thank you once again for having me here. All the best to all the contestants as well. Thank you so much.
Thank you, Dr.
Thank you, Dr. Sneha Bhuyar, for gracing this occasion and addressing this August gathering. Thank you so much with your presence. Thank you.
Now, like I'm again lucky to introduce Charulata Bapai as our guest of honor, and she's the youngest, but she's enriched with so much knowledge. I'm so lucky, so updated, so methodical, so charismatic. That is Charu Bapai for you. And she's director, James Hospital Endoscopy Center, Ashwini Hospital, Pune, and she's the chairperson now elect for Breast Committee, Foxy. And
thank you.
Charu
Thank you, Dr.
everything.
Thank you so much. So thank you for those kind words.
She's winning awards, accolades everywhere. Over to you, Charu. Please bless us and please address us.
Thank you so much for those kind words, dear Dr. Shashibala. And dear Dr. Varsha Basne, Madam, Chairperson of the IEC committee, but a fantastic Raja Yogi who has touched the hearts and lives of so many Foxians all over India. Well, to tell you the truth, I was feeling so conscious to be here as a guest of honor among such august audience. But you, in your typical fantastic, calming manner, put me to ease, and I'm feeling so lovely to be here as a guest of honor amongst all the stalwarts. So it is indeed an honor to be on the same dais as Dr. Pardeshi sir, Dr. Hara Patnaik, Dr. Ajay Mane, Dr. Sneha Bhuyar, and all our esteemed speakers also. We have such amazing talented coordinators and MOCs. Dr. Pratibha Singh, who's now chairperson-elect of this committee, Shashi Bala, my dear friend, best wishes to you, Dr. Rashmi, Dr. Ashwini, Monica. All of you are definitely going to do great justice in introducing our highly reputed speakers and the chairpersons who are going to be chairing these fantastic sessions. Well, the placenta indeed needs to be handled with a lot of TLC, tender loving care. But when things get out of control and out of hand, we all have to go to war. And I'm sure that all our esteemed speakers, Dr. Gorak, Dr. Hemant Deshpande, Dr. Sahu sir, Dr. Kuldeep sir, are going to go out of their way and tell us how we are going to handle this war, and not only handle it, but win this war against placental problems. I'm sure each and every person who will log into this wonderful webinar are going to benefit immensely for the same. Thank you so much for having me here as a guest of honor. Indeed, my pride and privilege to be a part of this August gathering. Thank you so much once again.
Thank you, Dr. Charulata Bapai. We are honored with your presence. Thank you. Dhanyavad. Thank you so much.
Thank you.
Now I request Dr. Monica to kindly take over. Dr. Monica. Dr. Monica.
Dr. Monica, are you there? Please introduce the chairpersons very well. Dr. Bharat Lanjewar and Dr. Dhananjay Patil. If she is not there, Dr. Pratibha Singh, please do the honor, because maybe the internet connection, she cannot join in.
So now I would like to, we'll start our first session, and first session, the topic is placentation, and we have two chairpersons, Dr. Bharat sir He is the president of Bhandara Obs-Gynae Society, consultant gynecologist and infertility specialist, and he is a faculty of NDVH Workshop, Kolhapur. So welcome, sir. And our next chairperson is Dr. Dhananjay Patil, sir. He is the president, Islampur Obs-Gynae Society, and he is presently consultant at Ankur Hospital, Islampur. So welcome, sir. Now I'll request Dr. Bharat, sir, to kindly introduce our speaker.
Welcome, Dr. Lanjewar sir, Dr. Patil sir, to this exclusive webinar on placenta, and Dr. Gorak Mandrupar to be introduced by you.
I think he is not.
I don't think both of them are here.
Yeah.
Can't see in the pan.
Dr. Dhananjay sir is joined now.
Okay.
Dr. Dhananjay.
Has he joined Saiti Priya?
Yes, ma'am. Dhananjay sir is there.
Yes, sir. Yeah.
Then
Over to
tell
Dr.
him to
Dhananjay.
unmute,
Dr.
yeah?
Dhananjay. Yeah.
Yeah, I could see Dr. Dhananjay Patil sir.
Sir,
Sir,
please
unmute
unmute
yourself.
yourself.
Dhananjay sir,
Yeah.
unmute yourself. Dhananjay sir, unmute kara. हाँ. We cannot hear you. Unmute kara.
Yeah. Yes. Now you can start.
Yes. Good evening, madam.
Good evening.
Yes. Good evening.
Sir, you'll have to introduce our speaker, Dr. Gorak, sir.
Yes. Dr. Gorak Mandrupkar is a very dynamic personality. He is IVF consultant in Islampur. He is my colleague. He has also started Angel IVF clinic in Wakad in Pune. He is chairperson of SOPs and Guidelines Committee AMOGS 2024, and recently we have heard him in AMOGS Aurangabad about the hypothyroid guidelines. He is member of Task Force National Policy on PPH of Government of India. He has also drafted FOXY guidelines about gestosis score on hypertension in pregnancy, which is very useful screening tool for screening the preeclampsia. He has also developed 2 medical Android apps, which includes anemia detection app and treatment app. With this introduction, I request Dr. Gorak Mandrupkar to start his presentation about placentation.
Thank you, Dr. Gorak Mandrupkar. Gorak bola to gestosis ही याद आता है, and his app. He has made it so famous and so doctor and patient friendly too. So Dr. Gorak Mandrupkar, you have out of box thinking, and that is getting advantage to all the obstetrician. You are not an obstetrician, but I thought you will give the justice for this first talk of placentation, because you have that knack to dig in and present it in different way. Thank you for gracing the occasion and accepting the invitation. Dr. Gorak Mandrupkar.
Just, Varsha, I wish to add his biodata.
Please, you should.
Already. And he's the first person, he's the first person now who has made the history and is created, and he has done a lot of work in thyroid and presented and the practice guidelines, standard practice recommendations. I think I request Dr. Gorak to display the link so that all they will access our own guidelines now in spot. Congratulations, yes. Dr. Gorak.
Thank you, sir. Thank you very much. Thank you very much for kind words, Pardeshi sir. And actually, you have given me that chance to be chair that committee, and under your able leadership only, we are able to formulate our guidelines, our own AMOGS guidelines, and they are the first one. These are the SPR, standard practice recommendations on hypothyroidism in pregnancy. And the experts from all parts of the Maharashtra, they have actually contributed in it. So these are our own guidelines. That is very important. And second thing, that my own teacher, Dr. Ramesh Bhosle sir, as well as Dr.
You have to unmute, Dr.
Sorry? Am I audible?
Unmute.
Ata hai?
Oh.
Yes.
Yes.
So, Dr. Zungare Madam, Dr. Gadappa Sir, they and Dr. Anuradha Ridhorkar, Dr. Sudesh Doshi, they have reviewed it. And chairperson of the Medical Disorders in Pregnancy Committee of AMOMS, Dr. Sneha Bhuyar Madam, she has actually taken that task to collect all the experts from the Maharashtra. And then a turmoil of discussions was going on. And after that, we could draft it. And later on, these were reviewed by the panelists or the esteemed members, as I said. So today, again, I am very much thankful to all of you for allowing me to talk in this very august gathering. In front of you all, I'm very happy. There was a problem that regarding the joining and also Dr. Sahiti or Miss Sahiti Priya, she will be displaying my presentation. I am very much thankful, Madam, for inviting me in this webinar. Actually, Nashik and my connection, I always consider her as my elder sister, and she has always called me for many occasions. And Madam, I am wishing you the very great success for your Foxy endeavors. Right.
Thank you so much.
Thank you, Madam. So today we are going to deal with a placenta, and in a little bit different manner, because we have to understand that placenta is nothing but it is the largest fetal organ, and it is the first to develop. I was there on Sunday in one CME where oration was given by Dr. Mashelkar sir, and he said that to be first is something different. And yes, this placenta has made a difference being the first largest fetal organ. It plays a central role in the health of both the fetus as well as its mother, and has a lifelong impact on their future well-being. And that's why this placenta and this placentation is very important. Next slide, please. Rosanes and the Pigenberg, they were the scientists who have done a lot of work in the modern obstetrics on placenta. Otherwise, till our PG days, the placenta was only something who was carrying from here to there and there to here. But a great work these people have done, and he has developed this, that the great obstetrical syndromes, they are associated with disorders of deep placentation. So this line has a very much importance, and these people, they have come out with this presentation, and this. Now we will go and we will see how this placenta actually develops. I hope I am visible. The next slide, please.
Yes, you are.
Sahiti Priya, you have to be little vigilant. Yes. The human placenta, it develops from the trophoectoderm, which is the outer layer of the pre-implantation embryo, right? This diagram, again, I have taken from their presentation only. This is very recently been published, and that's why we can easily see how actually the placenta develops. It is the outer layer. We can see there the ICM, and there is a development of inner cell mass, right? At this stage, the pre-implantation embryo, which is termed as blastocyst, it is segregated into two lineages, right? The one is inner cell mass. Above that, there is a cavity, and after that, there is TE, that is trophoectoderm, right? It looks like a custard apple, right? Which is hollow from inside. The polar trophoectoderm, it attaches to the surface epithelium of the uterine mucosa, that is endometrium, and there, next slide please, it implants. And following the implantation, if you see that slide, you can see that the primary syncytium, it quickly invades to the surface epithelium, underlying the endometrium, and it gets transformed during the pregnancy into the specialized tissue, which is called as decidua. If you see the previous slide, and if you see the next slide, this slide, then you can understand how this syncytia, it gets changed. Next slide, please. By the time, next slide, next slide. By the time of the first missed menstrual period, that means 14 days, DPF means the day past fertilization. The blastocyst is completely embedded in the decidua and it gets covered by the surface epithelium. We all know. You might be remembering maybe the first few lectures of the anatomy or the physiology in the first year. But yes, once we understand this, how the placenta develops, then we can understand many disorders of the obstetric. Not only that, but later on, because this placenta keeps the prints, some footprints there, and how the diseases of the fetus develop, we must understand. Now, fluid-filled spaces then appear in the syncytial mass. You can see there. You can see their lacunae, right? This is LAC is written, right? So they merge and partitioning it into a system of trabeculae, and this is called as the lacunar stage. Now the embryo or the blastocyst has gone totally inside the endometrium. It is approaching towards myometrium, we can say, going towards, but not in myometrium, but it is, you can understand that in that direction. The syncytium also erodes into the decidual glands, allowing the secretions to bed in that syncytial mass. So this is how now from the endometrial cavity, the baby has gone inside. That we have to understand, overlaying cover of that endometrium has come. Next slide, please. Here we can understand, yes, the completely now you can see the endometrial lining has come up on that upper part of that baby. You can see, or the upper part of the embryo, right? So it is completely embedment. Now the trophoblastic cells, which are beneath the syncytium, that means what we call them as cytotrophoblasts. Cyto means cells. So cytotrophoblasts, they are initially not in direct contact with the maternal tissue, but now they will rapidly proliferate to form the projections like, fingers. Like, so they start pushing through the primary syncytium to form the primary villi. Then these villus trees are formed by further proliferation. The primary, the secondary, the tertiary, you head to the maternal tissue. That means we can say in a simple language, the fetus starts approaching towards mother to get the food or to get all those things which he or she or that the fetus wants from the mother in a simple very language. Now cytoplasm cells, they eventually penetrate through this primary syncytium and they merge laterally to surround the conceptors in continuous cytotrophoblastic cell between the villi and decidua. Right? So now you can see there, the blastocyst is covered by 3 layers. You can see there, right? The inner is chorionic plate, right? Then villi, which are separated by intervillous space, and the cytoplastic shell in contact, which is with decidua. So from this diagram, we can come up that the baby is kept safe, not in direct contact with the mother, but a connection is being established through this villi. We should understand this. Why we want to understand this? Because this defective invasion is going to cause all those further disorders like preeclampsia, like the fetal growth restriction, and all those characteristics which that baby is going to get. How that baby is going to be thin, how that baby is going to be later on hypertensive, how that baby is going to be diabetic, and all those characters, they are going to come through this defective trophoblastic invasion. So we must understand, though we are saying preeclampsia in that 20-24 weeks, The problem is here at this early stage. So probably predicting these things at this much early stage, that is going to help us to prevent that disease. Second thing, to start the preventing things right from beginning, it is going to prevent that disease. Otherwise, the problem has already been begun, and if we start aspirin there, if we start stopping the carbohydrate diet, adding the protein diet, and etc., this is, sorry, phone handout was not, actually is not forgot, sorry. So these things are there. Next slide, please. This slide is very important, you will understand, yes, how the placenta develops. On the left hand down, there is primary villus, only cytotrophoblast. The secondary villus, where the middle layer of syncytial trophoblast has come, and the tertiary villi, where actually the blood vessels have started developing, appearing. How it develops, God knows. That nobody knows. But it starts developing. Soon afterwards, around day 17-18, the extra embryonic mesenchymal cells, they penetrate through the villus core to form the secondary villi, and by the day 18, DPF is again day post-fertilization. Fetal capillaries, they appear within the core, marking the development of tertiary villi. How? He knows. The villus tree continues to rapidly enlarge, and when the cytotrophoblastic shell is in contact with the decidua, that means maternal-fetal interface, individual cytotrophoblast cells, they leave the shell to invade into decidua as a extravillous trophoblast, that means EVT, in a process closely resembling the epithelial mesenchymal transition. And in this way, by the end of first trimester, that means at the end of, maybe at the end of 12 weeks, the blueprint of the placenta is established. And I will say here, the blueprint of further pregnancy, the blueprint of that baby, the blueprint or the program of that baby's health, it is fixed. So it is not that मग मी कुठल्या शाळेत जातो, मग मी पुढे काय खातो. No, this has been decided here at this 12 weeks of gestation age that we have to keep in mind. Now, what are the cell types of human placenta? One must understand. The major functions, next slide please. And the next. The major functions of the placenta, they are performed by trophoblast. And you know trophoblast, who gave this? Trophos means to give the nourishment, to nurture. That is trophos. And this term was first coined in 1889. जेव्हा अजूनही आपल्याकडे टुगलुक चाललं होतं, जेव्हा अजूनही ते ब्रिटिश आपल्यावर काहीतरी गोंधळ करत होते, अजून राष्ट्रीय सभेची स्थापना वगैरे चालली होती, त्यावेळेला this fellow has done a great work in embryology. And the term trophoblast was first used by him to describe the cells, those transport nutrients and are protective barrier between mother and fetus. He also observed that trophoblast is inherently highly invasive or corrosive. Very important. And it is dependent on decidua to support its development. Means to go, to penetrate, to take a benefit or to give a benefit, this symbiosis relationship that is being taught to us by this trophoblast that we have to understand. Next slide, please. The nourishment. Yes. The syncytial trophoblast is the outer lining of placental villi that is in direct contact with maternal glandular secretions and latter with maternal blood flowing into the intervillous space. But both of these blood flows, they never come in contact with each other. And that's how the baby's blood group may be different. This is something hemochorionic barrier. And it is the main site of the maternal fetal exchange of gases, nutrients, which are necessary for the growth of feto-placental unit. The microvilli, they are rich in receptors for the growth factors and hormones, and both the apical as well as the basal membrane of the syncytial, this SCT, they are packed with transporter proteins for amino acids and glucose. So mainly, this is how the nourishment gets transferred. Next slide, please. Endocrine. It is also a major endocrine organ because it secretes hormones and proteins into the maternal circulation to drive the physiological and metabolic adaptations to the pregnancy. That's why I always say, yes, now endocrine is a slide. No. Yes, this is the endocrine is a slide. Is it right, madam?
Yes.
Fine. So this is a major endocrine organ because it secretes hormones and proteins into the maternal circulation. And that's why I always say, even for IVF, once this placenta is developed and has taken over in a proper form, unnecessarily, the supplementation of the progesterone and other hormones is absolutely not required. Means the progesterone till 9 months and all. I'm talking from this stage as a researcher, as an IVF consultant, that unnecessarily the supplementation of these hormones is absolutely not required because it is not going to cause any benefit but the problem in the mother. Because the placenta has taken over and has sent all those what is required for the physiological as well as metabolic adaptations to the pregnancy. It is his creature and there is no problem. Next slide. Protection. Yes, it actually works like this. It is protective immunological barrier because it never expresses any HLA molecules. Meaning that despite the presence of allogenic fetus, circulating immune cells will not detect the SCT as non-self. That means whatever all those immunological diseases and all, it's a latter part, it's not now. This also expresses the neonatal FC receptors to allow the transport of maternal IgG antibodies to the fetal circulation. That means, yes, the protection is being transformed to the fetus. So that is maternal IgG antibodies to the fetal circulation. The antibodies that preferentially bind to this FcRn, that means FC receptor, on the SCT, they are digalactolized IgG1 molecules that are effective at activating fetal natural killer cells to protect the neonate before the birth. This is what mother gives to the baby through the placenta, right from beginning. This I'm talking at 12 weeks of gestation, from there onwards. So this is something great nature. Next slide, please. Do we know that the good project is going on? You know, we have completed that human genome project. Likewise, a human placenta project is going on. Those who are interested to give their contributions, they can type human placenta project. And yes, I'm working on a few of the lines, but yes, please work on that, human placenta project. Now, this is an important diagram, maybe 3 or 4 last slides. This diagram, one must understand in a very proper way. See, what happens as the placenta enlarges, the cytotrophoblast shell, it becomes discontinuous. And the cytotrophoblast cell columns emerge. See, there is a column, right? Where we have denoted it as CCC. This is nothing but it is a cytotrophoblast cell column, right? On the lower side, maternal side. Upper slide, that is a baby slide, right? That is a placental slide. So these columns, they emerge. The cells in the columns, they are rounded, they are cohesive, and they are rich in glycogen. Next slide, please. Yes, I'm keeping the diagram same. No, before that. Yes, I'm keeping the diagram same But understand, you see towards the diagram, that from the shell and later the anchoring villi, the EVT migrate. That means, what are EVTs? These are, actually they get divided into two, right? The one EVT is endovascular and another they are interstitial, right? See now there, if from above you can see there that the interstitial EVT, they migrate through the decidual stroma towards the maternal spiral arteries. You can see on the left down corner, there is a spiral artery which is red in color. Surrounding that, some of the cells are migrating, while on the right side, there are glands, and in between the gland and spiral artery, some of the cells are migrating. You can see that, right? Yes. Now, these endovascular trophoblasts, that means there we have marked it as EVT, they move down inside the spiral arteries. Next slide, please. This is a very important slide. One must understand. Next slide, please. Saiti. Yes. This is very important slide. In the decidua, the IEVT home towards the spiral artery to form a cuff surrounding the cells. You can see there, right? You can see there very clearly. I have shown the spiral artery you can see in between, and surrounding that there are cells. This is what they do. Do you know? They will cause loss of actin in the smooth muscle cells of the arterial media, right? So they have gone to the spiral arteries. Now they will vanish the actin from there, and it gets replaced by amorphous eosinic material, resulting in histological appearance known as fibrinoid change. All those spiral arteries, they get changed. What they do? They are now capable of high conductance at low pressure. So this is the beauty. And when this doesn't happen, or if this process is defective, if this fibrinoid change doesn't occur, then those spiral arteries, they remain tough, and a wave of vasospasm, it generates there as per the Wollard theory. It will increase the all those inflammatory markers throughout the body, and it will start, or it will initiate the problem of preeclampsia, or it will be responsible for the changes into the maternal and fetal circulation, later on leading to FGR, that is fetal growth restriction. So this is the change. Why and how it happens? Probably the genetics, probably it is our Asian origin, which is 11 times high risk than the Western population. It is the obesity. It is the anemia. It is the second or third baby of those hypertensive mothers. It is the familial dyslipidemia. It is the change in paternity maybe. So all these factors, what I am talking, these are nothing but the clinical risk factors which we have included in the HDV gestosis score. So probably all those factors, or some of them, when they are there inherently, it will cause the problem here, and that's how the preeclampsia or the IUGR starts. And I think the last second slide. Next slide, please. The IEVT invade as far as the inner third of the myometrium, where it is thought they fuse to form the placental bed giant cells. Next slide. After the arterial transformation occurs, next slide, please. Yes, the EEVT move in a retrograde manner down the artery to form a plug. See, we have shown there the plug in the spiral artery, and this will prevent the blood entering into the intervelar space until towards the end of first trimester, when the full hemochorial circulation is established. That means it will not allow the maternal and fetal blood to mix as well. So this is the beauty of the nature. Next slide, please. And this is the end of, I think, talk 2 slides. That abnormal placental development and pregnancy complications. And now after these slides, I'm giving the continuation to respected teacher, Dr. Hemant Deshpande sir, who will be deliberately talking on abnormal placentation. And that's why I'm very much thankful, madam, that you have kept the flow of this talk in such a way that this is normal placentation. I am entering into the abnormal placentation, and henceforth all those complications you will understand. So many complications of the pregnancy, they have their origins in the abnormal development of placenta in the first trimester. Preeclampsia, FGR, unexplained stillbirth, even placental abruption, preterm labor. These complications are known collectively as GOS, the Great Obstetric Syndrome, and defective trophoblastic invasion is the ultimate cause. And that we have to understand. After the gestosis, now our group is working on preterm labor. And so I urge all of you, please join our venture. And like gestational, the HDP gestosis score, we may be able to go on that preterm labor. Recently, Dr. Meeta Gupta from Jammu, she has published the very best paper on that. She has validated the score, and she has found out that 97% specificity to the score and almost 90% negative predictive value to the score. Though initially the researchers were saying that this score, HDP gestosis score, it may have high positive predictive value. No problem. ज़्यादा से ज़्यादा होगा, एस्पिरिन चला जाएगा 75 मिलीग्राम, कैल्शियम 1 ग्राम चला जाएगा, कार्बोहाइड्रेट बंद होगा, हाई प्रोटीन डाइट जाएगा, तो नो प्रॉब्लम. लेकिन जो 10.3% मैटरनल मॉर्टेलिटी अभी भी है, वो पूरा का पूरा कम हो जाएगा. नेक्स्ट स्लाइड प्लीज. So, trophoblastic cells invade into residua to gain the access to the maternal blood supply. If the arteries are not sufficiently converted and retain their contractile media, there is disordered perfusion of the blood flow. This, together with inadequate supply of nutrients, oxygen, reduces the progressive branching of the villus tree as gestation proceeds, reducing the surface area available for the exchange, with the possible outcome of FGR and stillbirth. Next slide, please. Preeclampsia results from the release of products of poorly perfused and stressed placenta into maternal circulation, triggering a systemic endothelial disorder. Next, please. Do you know one thing before that? Why we are not able to study this at a molecular level? The problem is the deep trophoblast invasion into the uterus. It is a feature, it is seen only in humans and the great apes. The defective transformation of arteries has been hard to characterize and hence diagnose early in pregnancy. तो अगर हमें ज्यादा का ज्यादा प्लेसेंटा का स्टडी करना है, तो या तो ह्यूमन प्लेसेंटा का करना पड़ेगा, नहीं तो एप्स में करना पड़ेगा. Otherwise, nobody resembles us. And this is why still there is an enigma. What actually happens in the trophoblastic invasion? Next slide, please. A number of clinical measurements are being developed to overcome this, like uterine artery Doppler velocity. Then see, there are emerging technologies are going on, cell culture technologies, then omics technologies, pregnancy biomarkers for the clinical usage, advanced imaging techniques are going on. But do you know what Dr. Mashelkar sir said in that oration of his innovation? It is Indian innovation. He said that it is the India who can give the excellence with adaptation and with in a very, very, very cheap, or not cheap, but in a very, what we can say, a cost effective. And that is the next slide. Next slide, please. Yes, it is the gestosis score. This is a very recently, that means it was accepted on my birthday itself. 22nd August of 22, this paper was accepted. It is a prospective study to determine the predictive ability of gestation score for the development of preeclampsia. And you can see in conclusion that yes, the sensitivity 83.1%, specificity 97.5%, negative predictive value 85%. Negative predictive value of 97% respectively for predicting the development of preeclampsia. This is just mere presentation of Jammu group. Still, Hyderabad, Kolkata, Kolhapur, Bijapur, Bangalore, Ahmedabad, they are in pipeline. So we are doing this study across the country, and we may be able to give the world the innovation, that is Indian innovation. So thank you very much. Next slide, please. Thank you very much for allowing me to give this precious presentation of placentation. And I hope that I may be successful.
Before the chairperson give concluding remark, let me talk a little bit about Gorakh. Your presentation was such a lucid and so detailed, like the microscopic. Such a foundation of the pregnancy, you evaluated it so well, studied research paper like, and I'm so happy you mentioned about exosomes. People do not know exosomes. My talk is on in this Kisar on next month on 7th of October. My talk is on recent advantages in stem cell at Bangalore. I'm going to talk on exosomes only. So exosomes are the biomarkers of pregnancy. They will tell you about what's problem, what is the stress, what is the, at the initial stages only you can diagnose if there is any problem or hindrance in the normal pregnancy or the pregnancy is going to be problematic. Such a lucid, it was delightful. It was, I'm so happy. Such a nice feast of academic excellence, really. Thank you so much, Dr. Gorakh Mandrup, for coming over here and delivering such elaborate deliberations. Thank you so much. Over to you, Dr. Dhananjay Patil, for your concluding remarks.
Thank you so much, Gorakh. It was a very good presentation as usual. You have taken us again to the basics of embryology. Take home message is we must know that how defective invasion of spiral arterioles cause complications like PIH, IUGR, and so many complications. So we have to start preventive measures in the first trimester only. He has also told us that progesterones are not required all over the pregnancy. And he has also told us the importance of gestation score to diagnose our high-risk patients. Thank you so much. Over to Dr. Monica Madam for next presentation, please.
Thank you so much, sir. Thank you, Dr. Dhananjay, sir, for chairing the session, and Gorakh, sir. It was an exhaustive and deliberate description of the entire placentation. I'm sure we would be able to understand the further lectures much better with your lecture. We now move forward with the topic of abnormal placentation and placenta previa. The chairpersons for this session would be Dr. Rahul Vani, sir. He is currently the president of Navi Mumbai Obstetrics and Gynecological Society, and he is a consultant at Archana Maternity Nursing Home in Kopar Khairnare at Navi Mumbai. We welcome you, sir. The second chairperson for today, Dr. Santosh Jaibhay. He is a postgraduate from KM Hospital, and he is a practicing obstetrician and gynecologist and a freelancing gynecologist. His special interest would be endoscopy. He is also the joint director at Om Sai Multi-Speciality Hospital at Navi Mumbai, and he is the honorary secretary of Navi Mumbai Society and the West Zone coordinator from Ethics and Medical Legal Committee, FOXI. And he's a passionate finance teacher and marathon runner. We welcome both of you, sir, to carry forward the session.
A kind introduction. Am I audible?
Yes, sir.
Yes.
It is my honor and pleasure to introduce Dr. Hemant Deshpande. We all know him as a great academician, a great teacher. He's a professor and head of department, Deputy Dean of Dr. D.Y. Patil Medical College, Pune, Dean Faculty of Medicine, Chairman BOS BPU, and he's written and edited many textbooks, He's written a textbook of high-risk pregnancy, polycystic ovarian syndrome, a clinician's manual. So many publications in his name, and we are waiting to hear from him, after Gorakh's insightful lecture. We are sure that Dr. Hemant Deshpande will put more insights into abnormal placentation. Thank you, sir. Over to you.
Before that, let me talk a little bit. Thank you, Dr. Rahul Wani and Dr. Santosh Jaibhave, the President Secretary from Navi Mumbai, for joining and chairing this important session. And I'm really thankful to Dr. Hemant Deshpande, sir, also, who has obliged and accepted the invite on behalf of Foxy International Academic Exchange Committee. Thank you, sir. Waiting for your deliberations. Dhanyavad.
Respected chairpersons, first of all, I am thankful to Varsha Madam for giving me this opportunity. Dignitaries of Foxy and respected Dr. Gangadhar Sahu sir and all my dear friends, a small talk on placenta previa basically, and please permit me to share my screen. Yeah. So I hope everything is seen here.
Yes, sir. Yes, sir. We can see.
Right. So this is a talk regarding placenta previa. So what's a placenta? The placenta previa, the word previa, that means it's a before, it's in front. Normally we all know what's a placenta, we call it as a afterbirth. First the baby comes and then the placenta. So for a long time it was called as a afterbirth. But when the placenta is coming in front of the baby, the placenta is coming in before the baby, this is called as previa, and this placenta previa creates lot complication to both mother as well as to the baby. One of the most important cause of the antepartum hemorrhage, the bleeding that occurs from the genital tract, from the uterus after 28 weeks of the pregnancy but before the delivery of the fetus. One of the most important causes is the placenta previa, and this placenta, we call it as a previa, when it is lying either partially or completely in the lower uterine segment. It's covering the interlos, it's near to the interlos, it's completely blocking the interlos. In any way, this becomes placenta previa. Usually at 20 weeks of gestation, when you send a patient for sonologist, maybe for the anomaly scan or maybe for any scan, you get 10 to 30% of the cases you find out the placenta is low-lying, little closer to the cervix, little closer to the interlos. But 90% of this reports, you can find out this placenta, they migrate to their normal position in the uterus. So at the end, you see an incidence somewhere between 1:200 to 1:300 pregnancies when the placenta literally down after 28 weeks in the lower uterine segment. It's a Janox-Campbell's classification. Eric Janox and Stuart Campbell, a beautiful classification. They have typed the placenta. Clinically, we can call them low-lying, marginal, incomplete central and central, but we can call beautifully as a type 1, type 2, type 3 and type 4. The 4 types of placenta previa, they are depending on the type 1 when the major part of the placenta is in the upper uterine segment, but the lower margin of the placenta that encroaches in the lower uterine segment, but beyond 2 centimeters away from the interlos. Type 2, the placenta is reaching the margins of the placenta, practically touching the interlos, but they are not covering it. We call it as a marginal because margins are touching to the margins of the interlos. Type 3, this is incomplete central or a partial central you can call. The placenta that covers the interlos partially. When it is in undilated conditions, but when its cervix starts dilating, it doesn't cover it. So we call it as an incomplete central or a partial central or a type 3 placenta. And type 4, a placenta covering the interlos like a lead. Central placenta, total placenta covering the cervix, either dilated or undilated condition. When such a placenta previa patient comes to us, it's really a terrible problem. Sometimes they come with a painless bleeding, little spotting, maybe a few drops, maybe a partial pad, a painless bleeding, maybe 28 weeks, maybe 30 weeks, maybe 34 weeks. We are all happy because bleeding is very much less. The mother's condition is good, the fetal heart sounds are good, the uterus is absolutely relaxed, no problem. But sometimes the other type of patient comes to us, a patient completely white, tap-like bleeding. Uterus relaxed, painless bleeding from the uterus, tap-like bleeding. The fetus may be dead at times, the patient may be pulseless. The BP may be 50, 60, 70 systolic with a pulse rate maybe around 140, 150 or 120 beats per minute. This is the condition. Two extremes of the cases, they come to the OPD. The first one, we are happy to tackle. Second one, we know we are obstetrician, we have to tackle, but they are really terrible one. This is the pictorial depiction of the type 1, type 2, type 3 and type 4 placenta. The reaching beyond 2 centimeter, type 1, reaching or touching to the interloss, type 2, covering the interloss in undilated condition, type 3, and lead on the cervix, the type 4 placenta. We even divide them as a major degree and a minor degree. It's not only the Janet-Campbell's classification, but a simple classification for the clinicians. As a clinician, we have to classify them major degree and minor degree. Type 3 and type 4, which are practically covering the interloss either partially or completely, they are major degree. But yes, there is another type 2 placenta. Type 2, we know it is touching the interloss, but when type 2 is on the posterior side, the placenta can lie on the anterior aspect of the uterus, can lie on the posterior wall of the uterus. When the placenta is lying on the posterior wall of the uterus, covering the area of the uterus, which is exactly in front of the sacral promontory and sacrum. Here, when the head tries to go down, the placenta is going to be compressed. And obviously, when compressed placenta, compressed villi, compressed sinuses, they block the blood supply to the fetus, and the fetal heart shows a lot of abnormalities. So type 2 posterior, again, we make them into the major degree. Minor degree, yes, type 1 and type 2 anterior, they are all minor degree, which have little bleeding at times, and obviously the mother's condition and the fetal condition is good here. So major degree, minor degree, and obviously the Janet-Campbell's. It's something theoretical part, why the placenta come down in the lower uterine segment. Normally it has to be in the upper uterine. Anterior wall 50%, posterior wall 50%. But why it comes down? It comes down because of something like a dropping down theory. Somewhere the decidua, they are defective, the placenta has to encroach in the lower uterine segment to get lot of blood supply for the baby. A large membranous placenta, a placental anomaly, which is not 15 to 20 centimeter in the diameter, it's 30 to 40 centimeter in the diameter. A large membranous placenta can go in the upper segment, can go in the lower segment, can cover the cervix, and that becomes again a placenta previa. Something like a persistence of the chorionic activity, again encroach the placenta in the lower uterine segment. So many risk factors for this particular placenta previa. Age of the patient. 0.5% incidence you see in less than 35 years, but yes, when the patient is more than 35 years, absolutely the incidence of the placenta previa is more. Multiparity, another risk factor for the placenta previa. And one of the most important risk factor is the caesarean section. The number of the caesarean section, the incidence of the caesarean section increasing nowadays is really a worrisome situation. There are so many hospitals in India who have shown more than 80% incidence of section, and some hospitals have practically shown 100% C-sections. And that's really one of the risk factors for the placenta previa. Previous 1, 2, 3, 4, as the number of the section go on increasing, the risk and chances of the placenta previa in that particular patient goes on increasing. Maternal smoking, another risk factor for the placenta previa, because carbon monoxide hypoxia can cause compensatory placental hypertrophy, and this enlarged surface of the placenta can come down into the lower uterine segment. Uterine leiomyomas, another condition where the placenta comes down in the lower uterine segment and becomes the placenta previa. In a patient who is having previous history of the placenta previa, the risk of recurrence is much more. We all know twin pregnancy, all IVF friends we know. 2 embryo transfer is our policy. And obviously when you have 2 embryo transfer, when there is a multiple gestation, twin pregnancy, at times triplet, a large placenta of twins, a large placenta of triplets obviously comes down in the lower uterine segment because of it's a larger surface area, and we know it's going to cause the placenta previa. And obviously subcenturate lobe anomaly also risk as a placenta previa. So the clinical picture is really important in placenta previa. The symptoms are classically of the vaginal bleeding. Sudden in onset, yes, without any cause, absolutely. Painless bleeding, most important feature. Ask the girl, is there any pain in abdomen when you started this PV spotting, PV bleeding, depending upon the amount? It's a causeless bleeding. There is no cause for this bleeding. It's the physiology of the pregnancy, it's the formation of the lower uterine segment, it's the distension of the lower uterine segment that's responsible for this particular bleeding. And obviously, it's a causeless one. It's a recurrent bleeding because the formation, the distension of the lower uterine segment is not a one-day job. It's going to occur in so many spells. It's going to occur in the spread of the time. And obviously, the moment the lower uterine segment is enlarged, the placenta gets separated from the LUS and it becomes a recurrent phenomenon. And obviously, variable amount. I told you it can be spotting, it can be few pads, or it can be tap-like bleeding. It depends on how many sinuses they are torn open. It depends on how many spiral arterioles are torn open. It depends upon how much is the vessel that's of the caliber which has been separated by the placenta is going to cause the bleeding. So obviously, most important thing, sudden onset, painless, causeless, recurrent, and variable amount after 28 weeks of gestation. Any time before the 37 weeks, any time before the delivery is the feature of the placenta previa. So many times we get something like a warning hemorrhage, a slight bleeding, maybe between 24 to 28, 20 to 24 weeks, the girl come. I have a painless spotting, maybe for 2 or 3 days, amount is 10 ml, 15 ml, no maternal fetal problems, mother's GC is absolutely good, the fetal heart is absolutely fabulous, fresh bleeding for 2 or 3 days, just spotting, maybe partial, one fourth of the pad, so amount decreases slowly, day 1, day 2, day 3, day 4, and stop completely by day 5. This is a warning hemorrhage. This is giving you a warning. Probably at 28, 32, 34 weeks, she is going to have a placenta previa, and the subsequent bleeding may be much more bigger in the amount. Recurrent bouts are absolutely, they are more than the warning hemorrhage. Subsequent episodes, obviously more in bleeding. They last for fresh bleeding for 1 to 4 days. Decrease slowly, become little darkens. Bleeding stop by 4 days, 5 days, 7 days by thrombosis of those sinuses which are torn open. Eversion and infarction of the separated placenta just turned up and stop the bleeding. And probably the pressure of the presenting part is also going to have a little impact on stopping the bleeding. How many episodes of a bleeding a girl can have? 2 to 5 is the maximum number. Commonly occur between 28 to 36 weeks of gestation. But remember, friends, type 4 placenta previa, which is central one, that bleeds only after 36, 37 weeks when the patient goes in labor. It never bleeds without the patient that goes in labor. In abdominal examination, what do you find out? The size of the uterus is absolutely proportionate with the period of amenorrhea. Yes. The uterus is relaxed completely, soft, elastic. No tenderness on the uterus at all. The persistence of malpresentation or breach or transverse or oblique or unstable lie is going to be there because lower part of the uterus is occupied by placenta. The head of the baby cannot come, so it has to be either in breach, oblique or transverse, whatever position the baby wished to be there in the uterus. If it is cephalic, the head is floating. And you can't push the head down in the pelvis. And obviously, at times, the placenta previa is seen in the multiple gestation. And the fetal heart sounds, they are totally dependent upon the amount of blood loss. For a mere spotting or just 1/4 of the pad, nothing happens, 140, 150 beats per minute. But if the bleeding is more, maybe 4, 5, 6 pads or tap-like bleeding, the baby show the distress, or at times, even if it is a tap-like thing, the baby even is intrauterine death in the uterus, which we can see. Type 2 placenta previa, I told, there's something like a Stallworthy's sign. It's very simple. The placenta lying on the posterior wall. It's above the sacral promontory. It's above the sacrum. When you try to push the head of the baby down, the placenta is going to be compressed between the head of the baby, between the bones of the head of the baby, between the sacral promontory and sacrum on the backside. And this compression of the placenta will decrease the blood supply to the fetus. And the more you are going to push the baby down, the fetal heart is going to be decelerated. The moment you release the pressure of your hand on the baby's head, head comes back, the circulation restores and the fetal heart comes back to its normal. Don't do this always. This is a stalwart sign which once upon a time was very much famous. Confirmation of the diagnosis. Clinically, yes, painless, causeless, recurrent bleeding, and soft uterus definitely gives you idea that this is nothing else than placenta previa. But confirmation is needed for localization of the placenta. Where is the placenta situated? Is it in the upper segment or lower segment? Confirm it by transabdominal transabdominal scan or TVS sonography. Confirm it by transvaginal sonography very gently. Don't put the probe too in the vagina. Or you can even do a transperineal ultrasound. That also gives you a beautiful idea about the placenta localization. A color Doppler flow study will also show how the placenta in the lower segment and how much is the color blood flow there. And obviously MRI. MRI always say when the patient is having previous 1, 2, 3, 4 sections and she is having placenta lying in the lower segment, confirm that it is not morbidly adhered placenta previa. The placenta accreta syndrome, PAS syndrome, is quite common with the previous cesarean section and placenta lying in the lower segment. MRI, gold standard. Give you a complete idea how much placenta in the segment, how much it is innervated, whether it is accreta, whether it is increta, or whether it is percreta and going, even in the bladder. So everything is going to be told by MRI, and that's going to give us absolute diagnosis, plan for cesarean hysterectomy, arrange everything and save the patient and save the baby. The use of TVS in diagnosis was done by Farin. The accuracy rate of TVS is very high. Sensitivity and specificity, you can make out practically 90 and 98%. Positive predictive value is 93% and negative predictive value is 97%. TVS, absolutely gold standard to diagnose the normal placenta previa, and obviously without when there is no cesarean there. There's a misnomer which always we heard when we were in the second MBBS, in the third MBBS, in the internship, in the first year of our PG, placental migration. Can it happen when it is implanted in the lower uterine segment? The placenta that lie close to the internos but not over it during second trimester may slightly move up. This is because of the relative growth of the upper and lower uterine segment. It's absolutely a misnomer, but yes, the difference in the growth of the upper and lower segment can make the placenta little moving up and makes it a placenta that's going in the upper uterine segment. After the section or after the vaginal delivery in the first and second degree placenta previa, can placental examination will tell us whether it is a placenta previa? Yes, a large and thin placenta, probably a tongue-shaped extension, everted margins, and obviously remember friends, whenever there is a placenta previa, and see the cord, where is the cord? Where is the cord attached? Is it attached in the margins? Is it attached in the membranes? So there are high chances that there could be a battledore insertion. Yes, all patients, I mean, so many sections we have done up till now in last 40 years of my career for placenta previa, marginal battledore insertion was 100% seen. I haven't seen a few rare cases as a membranous or in the membrane or velamentous insertion. And you can make out the range of the membrane. Membrane range is near to the placental margin. That will tell you in the first and second degree in a vaginal delivery, yes, it was a placenta previa. Now, what's the management? A placenta previa, we know we have seen two types of conditions, slight bleeding, maybe a few spots, maybe just 1/4 soap pad with a good maternal and fetal condition. And second one, a tap with white patient, pulseless, maybe BP may not be recordable, or maybe 30, 40, 50 systolic and dead pale with fetus either in distress or dead in the uterus. So management depends on the amount of bleeding. These two scenarios. Period of gestation, whether it's a mature, more than 34 weeks, more than 37 weeks, and obviously your hospital. Facility of blood transfusion, component therapies. I don't say blood transfusion now, we say component therapy. Just change the word now. And obviously the facility of cesarean section, a good NICU for the baby if there is a distress, and a good anesthesiologist who can take care of the patient, even if the patient's systolic BP is 40, and giving you a chance to do a section to save the life of the patient. So something is there, expectant line of management, a beautiful expectant line by this old man, Charles McAfee and Herman Johnson, from the Belfast Maternity Hospital, or it was called as a Belfast Lying-in Hospital. Aim to continue the pregnancy for the fetal lungs to mature, but without compromising the maternal health. You don't compromise the maternal health. Let the mother should be in good condition, hemodynamically good. And these are all criteria the patient should complete before we go for McAfee and Johnson's expectant management of the placenta previa. Little bleeding, just spotting or 1/4 pad, maybe lasting for 2-3 days. This much should be the bleeding, not more than that. Maybe a few episodes. The patient can have 1, 2, 3 episodes. Don't bother. But the bleeding quantity should be this much only. Good status of maternal health, hemoglobin more than 10, hematocrit more than 30, pregnancy less than 37 weeks or even 34 weeks, I can say. No active vaginal bleeding that lasted for 2-3 days and then stop. Fetal well-being, yes, absolutely fine. Fetal heart is good. Weight of the baby is good. Maturity is good, corresponding with the period of amenorrhea. And NST and USG showing the baby's well-being absolutely nice. And obviously, when your hospital have a facility of emergency section, because we don't know her next episode may be a life-threatening to her, so we have to do an emergency section. When all these criteria are completed, we can go for the expectant line of management. Give the bed rest to the patient, investigate the patient, all investigation, send the lab, do ultrasonography repeatedly, maybe every weekly or maybe every 10 days interval. Supplementation of iron, calcium, folic acid is mandatory. Maybe blood transfusion intermittently depending upon the hemoglobin of the patient. Don't do any PV examination, not to be done at all. No PS also, I as a teacher, I say, don't do neither PV examination or bimanual examination, neither a speculum too. Give dexamethasone, 6 milligram every 2 hourly, 4 doses for lung maturity. That's mandatory, and anti-D if the patient is RH negative. At 37 weeks, continue the pregnancy till 37 weeks. This is the expectant line of management. If it is a minor degree, placenta previa, 1 and 2 anterior, head lies below the placenta, do a gentle ARM or controlled ARM, start oxytocin drip and have the vaginal delivery. No harm in conducting delivery in minor degree placenta previa. If it is a major degree placenta previa, active bleeding, 3+ pallor, hypotension, tachycardia, hypovolemic hemorrhagic shock, either fetal distress or death. This is the scenario. Bad scenario sometimes in labor room referred patient or even in OPD. Accidentally somebody did a PV examination and then the placenta bleeds like a tap, both the conditions. Resuscitate the patient, give IV fluids, start oxygenation, arrange for the component therapy and shift the patient for emergency LSCS. The cesarean section in placenta previa is life-saving to the patient, life-saving to the baby. Lawson Tate from Birmingham did the first cesarean section as a treatment of placenta previa, rather advocated. Indications, type 3, type 4, type 2 posterior, malpresentation, maybe even continuous bleeding in minor degree, and obviously placenta previa, type 2 posterior are the indications of CS. Now, how to reach to the baby when the placenta is lying in the lower uterine segment, especially when in anterior wall. If it is in the posterior wall, absolutely fine. You open the anterior wall, deliver the baby, and everything in your hands and under your vision. When it is an anterior placenta, type 3, type 4, either you separate the placenta, rupture the membrane, deliver the baby. You have to do it very fast because when you separate the placenta, the blood which is going out, the bleeding which is going to occur, that's the blood which is going to the baby. So obviously, exsanguination of the baby should not occur. Or you cut the placenta and then deliver the baby. Again here, same thing. Do it very fast. Rapid delivery of the baby, either by separating or cutting. You're going to save the baby. And you know the fetal blood loss, you have to do as less as possible. Time required for both the things, I used to do both the things, is practically same. There is no difference in the time. Suturing the lower uterine segment when the placenta is on the anterior wall. Yes, soft friable LUS. Risk of cutting through of your suture material can occur. You have to secure the angles gently and suture it meticulously without causing tear or cut through. Difficulties are absolutely rare. Sometimes you may have to take bed box stitches. Sometimes you have to ligate the uterine. And obviously, I did the interiliac artery ligation in a couple of cases. And the bleeding is one much more. And we may have to resort even hysterectomy, cesarean hysterectomy in those cases. Risk to the patient in placenta previa, obviously, we may have to do emergency hysterectomy. Sometimes a thromboembolic condition can occur, bladder trauma, ureter trauma may be there. I have never encountered all these situations, but these are all theoretical things which you have to keep it in mind. Some maternal complication, bleeding, malpresentations, preterm labor, cord prolapse, because cord is lying very close to the margin. When you're type 2, type 1, obviously you are doing ARM and permitting delivery, cord prolapse can occur, increased incidence of operative interference, and PPH and APH is also there. Lower uterine segment is not going to contract, is not going to retract. It's a segment. This is one which the sinuses may remain torn open for a longer time. Puerperium, little sepsis, subinvolution, sometimes embolism, again rare. Renal failure and DIC when the patient had tap-like bleeding and she has absolutely exsanguinated with pulseless BP not recordable and dilutional DIC, and the blood supply to effective plasma renal flow, when it is going to be reduced to the kidney, she may have acute renal failure or DIC. Again, in time, if the patient referred, all these complications can be tackled. The birth asphyxia, low birth weight, and intrauterine demise are the fetal problem which we have to encounter. Morbidly adhered placenta previa, one more condition which I am not going to deal today because already this is a separate entity, PAS, placenta accreta spectrum. A separate a talk has to be arranged on this particular topic. Morbidly adhered. The more number of the C-sections, the more chances of morbidly adhered. So increta, accreta, increta, and percreta, they are all morbidly adhered placenta, and we have to tackle them. We have to diagnose them by MRI, and obviously MRI is a gold standard to diagnose this particular condition. And once you know the diagnosis of morbidly adhered placenta or a PS spectrum, then we can arrange everything and manage the patient absolutely in time. So planned management, planned cesarean section, cesarean hysterectomy in such condition will save the baby, will save the mother, both. We have done so many planned cesarean hysterectomy in my institute. In last year, I have done practically 17 obstetric hysterectomy. 10 out of the 17, they were of the placenta, accreta, increta, or one was placenta percreta. So deviation of accreta comes from the Latin word, this to adhere, and obviously this morbidly adhered placentas need to be managed very meticulously with a good teamwork, with a good backup of the blood bank, with a good backup of the HDU, and this is the unit which every hospital must have. So placenta accreta, they are attached to the myometriums. Increta, they penetrate in the myometrium, and percreta practically touch to the peritoneal surface or serosa. Worst things. Sometimes even the placenta can encroach even in the bladder, posterior wall of the bladder. So all three variants, they are encountered. You can make out their incidence. 80% accreta. Just at times even maybe separable too, maybe focal, maybe total. 15% increta in the myometrium, and just 5% they are percreta. So that means excessive morbid adhesions, they are, or serious morbid adhesions, they are reasonably less. So placenta accreta index is there by RAC. So many things are, it's an ultrasound index. Sir is there who can guide us on this particular index in his talk. Loss of retroplacental clear zone, irregularity, and width of the uterine bladder interface, small myometrial thickness, present of lacunae, bridging vessels. It's a 9-point scale, which we call it as a placenta accreta index. Just a theoretical thing for the postgraduates, not for the practitioners, because we manage the patient as per the clinical condition. MRI gives us guidelines, and that's the diagnosis for us. Cesarean delivery and hysterectomy, or a cesarean hysterectomy, is the answer for all these things. So at the end of my talk, a beautiful poem for you to remember what the placenta previa is. We had a beautiful rhyme that was there for our grandkids, which every one of us taught them. Mickey on a railway picking up stones. There came an engine and broke Mickey's bone. Ah, said Mickey, it's not fair. Who said, drive, I don't care. We taught all our grandkids. I taught my grandkids. And on the same rhyme, just a rhyme for placenta previa. Placenta in the lower segment, lying down there. When the alveolus forming, it bleeds and shear. Ah, said mother, I may have hemorrhagic shock. Fetal distress and demise may finally rock. If the bleed is less, McAfee and Johnson will back. If the bleed is more, open immediately the sac. A small poem that will tell you every crux about the placenta previa. And thank you for a wonderful opportunity given to me by Madam Varsha, and thank you everyone for the patient hearing. Thank you, guys.
What a deliberation, what a topic, and what a justification that you have done for this subject, Dr. Hemant Deshpande, sir. You are teacher of teachers, and your experience of 40 years that was exuding all over, and you gave us really good guidance about how to tackle this placenta previa, which is a dreaded complication of pregnancy. Thank you so much. Over to you, Dr. Rahul Wani and Santosh Jaiba, for your concluding remarks.
It was an excellent talk. You covered almost everything related to placenta previa, right from the diagnosis to clinical management to conservative management, right up to obstetric hysterectomy. I am 100% sure that everyone was completely glued to their seats and watching and hearing you talking it with intense passion and the passion which only a teacher can have while teaching his students. Thank you so much, sir.
Thank you, Santosh.
Yes, Santosh has summed it very well. Thank you, Dr. Varsha, and let us be in between the galaxy of stars. Thank you. Thank you.
Thank you so much.
Thank you. Thank you, everyone.
Thank you, Rahul sir and Santosh sir, for chairing the session. Hemant sir, thank you so much for taking us through the abnormal placentation so beautifully. We now invite the chairpersons for session number 3, Dr. Swarupa Iyer and Dr. Sandhya Saharan. The session is Abruptio placenta by none other than the teacher of teachers, Dr. Gangadhar Sahu sir. Our first chairperson, Dr. Swarupa Iyer. She is from St. GS Medical College, and she's a consultant obstetrician and gynecologist at Curie Hospital. The next slide, please. Dr. Sandhya Saharan Madam is an immediate past president of Thane OBGY Society. She is also the honorary joint secretary of PCOS Society of India, and she is a active member of PSC Committee FOXY. She has special interest in endoscopy, PCOS, infertility, and yoga. We welcome both of you, ma'am, to take the session forward.
Thank you, Dr. Sandhya Saharan and Dr. Swarupa Iyer for joining as a chairperson and taking the and accepting the invite. Sandhya, तुम्हारे क्या कहने? You are an all-rounder and you really, wherever you go, you make it very famous by your presence. Maybe it is academic or maybe it is a cultural program or whatnot. Your presence is felt everywhere, and you are really all-rounder person. I'm really happy to have found a friend in you. And Dr. Swarupa, thank you so much for accepting the invite to be a chairperson. And Dr. Gangadhar Sahu sir, what should I say? Just I asked you and you said yes. So such a grounded person, such a humble and loving, and every day your messages of positive behavior and whatnot, the beautiful flowers and everything, you make us our day every day a fresh day and good start of the day. Over to you, Dr. Gangadhar Sahu. Thank you so much for accepting this invite and giving us this your deliberations. We are all waiting. Yes, Dr. Sandhya and Dr. Swarupa, for your kind introduction.
Thank you so much, Dr. Varsha, for those lovely words. I'm totally humbled and overwhelmed. And it's my privilege to be here today among such a galaxy of speakers. I'd like to welcome Dr. Gangadhar Sahu. Sir has an illustrious CV, retired professor, HOD, OBGY, VSS Medical College, Sambalpur, Odisha, Dean IMS and SUM Hospital, Bhubaneswar, Pro Vice Chancellor, SOA, deemed to be University, Bhubaneswar, President, ISOPAP 2223. Sir has so many laurels to his name: principle of life, never to be a defaulter, dream to be a ladder of success for others to climb up, a disciplined learner, passionate teacher, versatile orator, a preacher of human values, writer, philosopher, team leader, gifted healer, and an ordinary human being. That is surprising. It's not so, being surrounded by extraordinary friends and well-wishers. The most beautiful CV I've ever read. Welcome, sir, and over to you for your deliberation.
Thank you. Thank you, Varsha madam and madam, for these nice words. So I was just listening to the two previous great teachers, and I was totally spellbound, and I was lost nowhere here. My granddaughter, reading in class 6, came and said, "Grandfather, now it is your turn." Then I woke up, gained my consciousness, and I hope I will tell something about Abruptio placentae and something different also. So, blessings from Lord Jagannath and greetings from Odisha. I hope everybody will be in good health. I will be different on my talk. I will give an overview of Abruptio placentae, then something about the care in antepartum hemorrhage cases, bridging the gap in the quality care. So my teachers, just before going to the overview, while we were postgraduate students, my teacher, mentor, Professor Umakanta Nanda, was teaching us, have a knowledgeable look to the placenta. Have a knowledgeable look to the placenta. If you have got no brain, how can you analyze the placenta? That is after delivery. But in today's world, with the advancement of science and technology, when the imaging science is there, so that those words also stand good in today's context. While doing an ultrasound or MRI, have a knowledgeable look. A fraction if you miss, it is a great loss, not only for the mother, fetus, the obstetrician and the institution. So therefore, always have a knowledgeable look. In the postgraduate examination, I was just asking to one of the students that tell me one most important difference between placenta previa and Abruptio placentae. Most probably Professor Deshpande has left it for me. And the answer he gave, I want to tell that Abruptio placentae is an intracranial hemorrhage, whereas placenta previa is just a vaginal bleeding. I was amazed. And no second question was asked by any of the examiners to that student. So with this background, let me go to the overview. My previous slide, please. So Abruptio placentae is that when a normally situated placenta, that means the upper segment, it separates and bleeds after the period of viability, that is 28 weeks. So there are different classifications, but the most pathological classification is that is retroplacental bleeding. It can be marginal bleeding. It can be preplacental or subamniotic bleeding. So most common and dangerous is retroplacental bleeding. When the blood collects in between the fetal side of the placenta and maternal side of the placenta, gradually it accumulates. 60 ml of blood can cause catastrophe to the mother. And from that, the clinical classification is either it can be concealed when no bleeding outside, but blood collects in the retroplacental space that has got enormous capacity to separate the placenta, and it can cause death to the fetus as well as to the mother. It can be revealed when the marginally or the subamniotic type of placenta, when it separates from the margin, so bleeding can be just like placenta previa. And another, which is very much confusing, that is mixed, where both the placenta will be, there will be revealed as well as concealed, particularly in the large size of placenta. So in those cases, next thing is the pathogenesis. Already Dr. Gorak has got so much in-depth knowledge in the basic physiology of placentation. I'm surprised and amazed. So we people should learn those ABC of the basics. So what happens? The pathogenesis starts in the placental bed, and the culprit, as he has repeatedly told, that it is the spiral artery, and spiral artery in the trophoblastic cells, which line the endothelium of the artery. So what happens due to any cause, either due to atherosclerosis in case of hypertensive disorders of pregnancy, or due to capillary narrowing, or due to thrombus formation, then avascular necrosis, when there is bleeding starts, that bleeding cannot be stopped. If automatically, by the grace of God, it stops, that is so good, or else it will create that a subcapsule, sub-retroplacental clot will increase in size and gradually separate it. So that is how the pathogenesis occurs. Coming to the risk factors, the common two causes that we were taught in the undergraduate classes, one is toxemic, another is traumatic. Today also that stands. So hypertensive disorders of pregnancy, one of the major causes of abruptio placentae, and vasospasm is the pathogenesis. The other one is trauma due to any cause, maybe due to obstetrical maneuvers like version, maybe due to blunt trauma or any road accident, whatever it may be. Apart from that, the other things which have come up are the one is hyperhomocystinemia, another is lupus anticoagulant syndrome itself, PPROM, and other lifestyle changes which causes this. One is late age marriage that could have been prevented if we could have followed the law of biology and could have married esteemed mothers by 21 years, completed their family by 25 or 30 years, then these complications could have been rare. Next thing is cigarette smoking and cocaine use, common for both placenta previa as well as abruptio placentae. Clinical examination is the mainstay for the diagnosis of placenta previa. A clinician like Professor Deshpande, if he can put his hand on the abdomen when the patient complains of pain followed by bleeding and reduced fetal movement or loss of fetal movement, then the feeling itself can write the diagnosis on the wall of the abdomen that it is abruptio placentae, and abruptio placentae, nothing else. So a tender, contracted uterus with difficulty in palpating the fetal parts, difficulty in localizing the fetal heart sound. On vaginal inspection, there will be a dark colored bleeding or maybe fresh bleeding, then in 99.9% cases, it is abruptio placentae. The diagnosis your fingers will tell. Imaging, in contrast to placenta previa, ultrasound will create a mess out of it. It is not that much diagnostic for the diagnosis of placenta, abruptio placentae, because in which stage of the blood that is being collected in the retroplacental space, accordingly, the echogenicity that will be projected in our screen, that will tell us. So here particularly, ultrasound becomes inconclusive if it is bleeding. And there is a yellow sign that is known as, because of the blood clots, when it is pressed by the transducer, and again when the transducer is removed, those clots will again bounce back. So that feeling or sign is known as yellow sign. That is called oval jiggle of the clots inside the abdomen. That means retroplacental space. Yes, MRI is diagnostic, but it cannot be done in a serious patient. A stable patient with uncertain diagnosis, it can help. Other investigations.
Sir, are the slides moving? Excuse me, sir. The slides are not moving, or you are on the same slide?
On the same slide.
Okay,
on the same slide. Point wise, I am telling madam.
Okay.
In the same slide. The other investigations are just indirect, measuring the D dimer after coagulopathy, alpha fetoprotein after leakage of the placental tissue into the cells into the blood, so also increase in the beta HCG. The management is very simple and very difficult. Very simple in the sense, if the patient has come to you in the early stage and you are a very good clinician and have a brain like Varsha or Madam Deshmukh, then without waiting for sending the patient to ultrasound, you can then and there do an ARM and save the patient and starting to induce. So as a good clinician can save it without any delay in the consuming the time for sending the patient to ultrasonography or asking or advising for MRI. So vaginal or cesarean, that depends on few factors. Number one, gestational age. Most important is the severity or seriousness of the patient, which demands the early delivery or quick delivery, and then is amount of blood loss. So accordingly, your medical management and obstetric management both will continue. In the medical management, blood transfusion and fluid management, that is important. And the medical management role of corticosteroid, particularly in prematurity. In this case, prematurity is very common. So if it is below 34 weeks, you can give 2 doses of betamethasone 24 hours apart, 24 hours apart. So 2 doses, that is sufficient. So then next, coming to the complications regarding this, there can be fetal complications and maternal complications. Maternal complications, number one and the most dangerous is coagulopathy, consumption coagulopathy. Second is shock, and the target organ is the kidney. So renal failure, coagulopathy, and hemorrhage. These are the 3 immediate major complications associated with abruptio placentae that should be kept in mind. Next slide, please. Now coming to why we are concerned. Because 1/3 of all antepartum cases have abruptio placentae. Up to 1% of all pregnancies is abruptio placentae. Maternal mortality is up to 1%, but the fetal death rate is 20 to 70%. This is the most dangerous statistics I have encountered. That is, fetal death is 20 to 70%. So in objective, that is how to give quality care in those cases, my objective is to reduce the maternal, fetal, and neonatal morbidity and mortality. So what should I do next? So my thing is, the strategies will be, if it is prevent the preventable, delay the inevitable, treat the treatable, cure the curable. If it cannot be cured, must be endured. So on that principle, I will proceed. If it is in the stage that I can prevent it, I'll go for either primary prevention or secondary prevention. What is that primary prevention? I know what are the predisposing factors. Even in the counseling stage, preconception counseling, from that stage, if the lady is elderly, history of hypertension, so and so forth, all these cases, we can start folic acid from that stage, and also low dose aspirin to those cases. We can start it. And second is change in lifestyle. Already I have told. One thing in our hand is we can advise our medical students to marry at the early age. At least lady gynecologists should not face this problem themselves. Then smoking and cocaine, they can avoid that. Trauma, because traveling is a fashion nowadays. Now Barsha madam is going for Turkey tour. So I am not after that. So while traveling, madam, take care of abruptio placentae. If those type of,
There is no person who is pregnant as a passenger or as a member. We are not carrying anybody.
Okay, thank you, madam. Thank you, madam. And next is prevention of or preventive steps for hypertensive disorders of pregnancy. In such cases where already the gestosis master was telling that according to the gestosis score, if it is 3 then or more, then we can start, that is low dose aspirin, 75 milligram daily. Then reducing the primary cesarean section, yes, myomectomy, cesarean sections, both scars are also responsible for abruptio placentae. So secondary prevention, particularly, already I have told, that is early diagnosis and treatment. In the early cases, you can find those cases where the first trimester bleeding history is there. If it is placenta previa is excluded, low-lying placenta, then we can think that in a normal placenta, there might be some subchorionic bleeding, which may in later stage, it can give rise to. So we can think in that line. That is first thing in the first trimester. In the second trimester, during routine ultrasonography, then again, you can suspect or exclude placenta previa, that is number one. Large placenta, twin pregnancy, all these things, which can also help for, corroborate to that. And uterine Doppler, that can also corroborate with hypertensive disorders of pregnancy. So early diagnosis and treatment can save us. Next, madam. So management strategies are, next please, one is medical management and another is obstetric management. Already I have told. That to improve the hemoglobin concentration, because we know that at any time she may bleed, one of my gurus was telling that whenever you suspect or diagnose a case of placenta previa or abruptio placentae, think that you are sitting on a dormant volcano. You do not know at what time it will explode. So similarly, be prepared for everything. So previous one, madam. Next one, next. Yes. In these cases, we should avoid a delay in 3 steps. Delay in decision to seek care, delay in reaching the care center, delay in receiving the quality care. So very important, starting from our ASA level up to the specialist level, everybody should be aware of this. History of bleeding means be suspicious that it may be placenta previa or abruptio placentae. Pain with bleeding means it may be abruptio placentae, your first diagnosis. So keep in mind, immediately consult. Delay in reaching the care center. So that is $1 million question now. You can see in a busy traffic, even in the ambulance, patients will bleed to death. A VIP is going on the road, ambulance is not able to move forward, road is blocked. So a dharana is going on, so and so forth. So imagine the health care. Delay in receiving quality care. That is the teamwork once it reaches in the hospital. Whole team starting from the receptionist to the obstetric care, that depends in the coordinated way where there should not be any delay. Next, please, madam. So these 4 R's are important. You should be kept in readiness, that is your team. Once such a patient comes, whole evaluation and management both should start so that there should not be any delay there. Recognition, next slide please. So recognizing the problem particularly for the patient, assessment regarding the diagnosis, the type of bleeding, the amount of bleeding, whether it is concealed or revealed, and then what might be the amount of the blood loss. Accordingly, not only blood will be arranged, but we should start the line of management for this abruptio placentae. Response, particularly that unit is responsible how to manage it. As I have told, the medical management and obstetric management. We know in most of the surgical complications, the delivery is the final treatment. It may be severe preeclampsia, eclampsia to save the mother. Delivery is the treatment. Therefore, in some cases like abruptio placentae, immediate delivery may be required. That how quickly you respond to this. And reporting is very, very important, because if everything is being documented, not only it will help us to analyze our mistakes in this case, it will help to rectify the mistakes in the forthcoming cases, in the subsequent cases. Next, please. Next, please. Next. So now to render quality care, these are the steps that should be provided. Safety, I always say, it is a relative term. When Lord Shiva was not safe from Bhasmasura, when Mother Sita was not safe from Ramayana, when our Prime Ministers Indira Gandhi and Rajiv Gandhi were not safe, how can you ask for safe? So you see, so therefore it is a very, very relative term. But as a medicine, I mean as a physician, as an obstetrician, when we have taken oath that because God cannot be everywhere, he made mothers. And at the same time, he made a brand of specialized physicians called obstetricians like all of us to save those mothers from hemorrhage, hypertensive disorders, sepsis, and malnutrition. So we have to try our best. We must give effective management, which is evidence-based and which is acceptable to each and everybody, that cannot be challenged. Our management should be patient-centric. We must counsel them without killing time, that this is for life-saving and also for the best interest of your intrauterine baby. Therefore, that is patient-centric. And timely, we should not waste even a minute on any plea or any reason providing the service, particularly in emergency cases. So reduce the wait time and delay in providing service for patients. And it should be efficient. That means the skilled person, most skilled hand available, should be ready there to render service for this. And there should not be discrimination that this is the driver of our minister, or this is a medical student, or the doctor herself. Most of are these now suicide cases in Rajasthan. So therefore, there should not be discrimination in rendering this treatment. Then only we can keep our dignity and respect in the society. Next, please. So there are two case scenarios. Because of the scarcity of time, I am skipping the first one. And the second one, next please, next. Yes. A senior consultant conducted a successful vaginal delivery with episiotomy in a case of preemie 36 weeks pregnancy with normotency with history of, vaginal bleeding. A healthy, mature, that means APH. A healthy, matured female baby was delivered. Then the senior consultant asked the resident surgeon to repair the episiotomy wound and left. After half an hour, he got an emergency call to attend. Imagine what might be the scenario and how the case could have been managed. I was that senior consultant, madam. Just I have reached home, I got a call that, sir, please come. It was in the evening. It was in the rural medical college I was serving. I was the assistant professor. Then the electric light is gone. I reached, rushed to the lab, OT, and found everybody is helpless, just praying God. Then I saw that patient is pouring blood. So the one message I want to give to all my friends, that every APH is a cause of postpartum hemorrhage, PPH. It may be placenta previa, it may be abruptio placentae. Once it is APH, gives rise to PPH, the basic message is that the consultant should not leave the OT or labor room without the vagina is being cleaned and is assured that there is no bleeding, it is a dry. Then only he can or she can leave the labor room or OT. Without that, for heaven's sake, never do that. In that case, immediately I asked for a hysterectomy trolley and giving a bimanual message by a postgraduate. Then immediately the trolley was ready and I went for, because with torchlight, I went for total hysterectomy because it was a placenta previa case. So in that case, don't experiment. Don't say that I should have gone to stepwise devascularization and internal iliac ligation. Never. On which you have got mastery, do that. When I felt that it is life-saving, I did the hysterectomy. Next, please. So, madam, quality improvement is a journey, not a destination. It is a continuous process. We will be facing difficulties. We will be remodeling it. We will be committing errors, because to err is human, but you should do no harm to the patient. You must be rectifying it. Next, please. So to conclude, I can say every mother is destined to bleed. Every mother is destined to bleed. but she bleed for a noble cause, that is the maintenance and sustenance of the human species. But she should not bleed to death. As long as Gangadhar Sahu is there, Barsha Madam is there, Deshmukh Sir is there, Gorak is there, Dr. Gorak. Next, please. Even if such situation comes where you are undone, your hands are raised, totally helpless, then surrender before God, Lord Vishnu, Lord Jagannath, and recite this sloka from Gita. Sarve dharman paritejya mamekam saranam praja aham tvang sarvapapebhyo mokhi samimashucha. O Lord, save me. I have surrendered before you. You do anything you like. If you have saved Draupadi in that Kurusabha, you have saved many, those who have needed you for your devotees. I am your devotee. The patient is your devotee. Save me, save my patient. Thank you very much, Varsha Madam, for giving me this opportunity to interact with you, to give some of my views regarding this.
Thank
Even if
you
in the
so
first
much.
invitation, even if in my first
Thank you so
invitation
much.
I could not make up to come to the school.
Yeah.
Thank you.
That's why I'm particularly invited you. Thank you so much. We are so much honored by your lucid and you really took us with your talk, how to deal, what is the cause, and the ultimate truth you told us to take care of the patient as God, and God is also helping those people who are really sincere in their intentions. Thank you so much, Dr. Gangadhar Sahu, sir. You really raised the bar very high. Thank you so much. Over to your chairpersons.
Thank you, sir. That was indeed a very, very elaborate talk, right from the description to the types and how to diagnose an abruptio placentae. It's a bane of every obstetrician. And very importantly, the 4 R's of quality care, which you stressed upon, and the important message which you gave, that just delivering a patient is not a job done. In fact, the 4th stage of labor, which we say after the patient delivers, is also so crucial in obstetric care. And now we have all standardized systems, SOPs in place where the obstetric units are geared to look. So I think these kind of drills are very important, where the staff as well as the residents are trained to handle such situations. Thank you, sir. And of course, it was divine grace that you started with Jagannath ji and ended with Bhagavad Gita. So what more can we mere mortals say? Thank you so much, sir.
Over to you.
Thank you, ma'am.
Dr. Monica.
We now move forward to the next session, and Dr. Sashikala ma'am will carry forward the session now. Thank you so much, ma'am.
Thank you, Monica. Now the 4th session of the day. We have speaker Dr. Kuldeep Singh. We are waiting to hear from him. And we have for this session chairpersons Dr. Shilpa Hambire, Secretary. She's from Osmanabad. She's Secretary, Society of the Osmanabad, ex-treasurer, OB-GYN Society, Osmanabad, and she's practicing since 12 years in Osmanabad. Welcome, Dr. Shilpa. Over to you. And also, her co-chairperson is there, Mr. Vishal Ramesh Patil, and he's from Dhulia. And he's also, he's done his MBBS in 2004, TGO 2006 from Dhulia. And he's now the president of Dhulia, OB-GYN Society. I welcome the chairpersons, Dr. Vishal and Dr. to conduct the next session. Over to you, Shilpa.
Okay, thank you, madam.
Thank you so much, chairpersons, for joining and gracing the occasion. Thank you so much for accepting the invite. And Dr. Kuldeep Singh, sir, you are the master blaster of USG and really waiting for your deliberations. Thank you so much for accepting the invite from Foxy International Academic Exchange Committee. And just, we are really blessed to have you all. Thank you. Over to you, chairpersons.
Good evening, everyone. At the outset, I would first like to congratulate Dr. Pardeshi sir for his victorious AMOS at Aurangabad. Also, I would like to thank Dr. Varsha ma'am for making me the part of this wonderful academic activity. We are truly looking forward for the next AMOS, which is going to be held at Nasik.
Yes.
The next topic is USG studies of placenta during pregnancy, and the speaker is none other than Dr. Kuldeep Singh sir. Dr. Singh sir is a passionate master trainer in the field of ultrasonography. He practices at Delhi. He has more than 300 talks in national and international platforms. He received 4 awards and 3 gold medals in the field of USG. He is the proud author of 16 books on ultrasonography. He was awarded the Imaging Science Award in AICOG Delhi. He runs the prestigious Sono School. He is going to launch VQUAL, that is V question and U answer and learn, that is, which is a basic and advanced academic program. Over to you, sir. We are waiting for your informative and interactive session.
Thank you so much. I hope I'm loud and clear and everyone can hear me.
Yes, sir.
Yes, sir.
Yes, sir. Perfect. I'll start sharing the slides. Thank you, Dr. Varsha ma'am, for inviting me. It's always a pleasure, and that's what I always say after service, because this topic as such that you've chosen, all about placenta, something really very, very nice and very comfortable, because there are so many things that we're going to be doing. Dr. Gorak, Dr. Deshpande sir, Dr. Sahu sir has made my work easy in terms of they've told about the clinical history, the symptoms, and I'm going to be telling all about normal placenta, placenta previa, a little bit about the variations, and I'm going to be talking about the placenta accreta in a little more detail. And at the end, I'm going to be talking about what are the new things. Why are we looking at the placenta so much? Thank you, Pardeshi sir. Thank you, Ajamani bhai. Thank you, Dr. Sneha. And it's always a pleasure to be with you all. So this is how you're looking at a normal placenta. It has to be homogeneous. And where you're looking at these arrowheads, that's a thin, clear space, which we all have to be looking at. There you're looking at the placenta. I hope the video is moving fine, doctor. Is the video moving fine? Is that okay?
Yes, yes. Perfect. Yes, we can see.
Looking at the placenta, we are supposed to be carefully looking at these spaces, but not worrying about them. You're supposed to be carefully looking at the myometrium behind the placenta, and you're supposed to be looking at this clear space, which I'm going to be referring this now. So there you're looking at these various variations. You can have a filamentous insertion, a subcentriate lobe, circumvallate, circumarginate, a battledore placenta, bilobe. Just be careful. Do not start measuring things. Be careful of looking at, doing and eyeballing as to what you're really looking at. Again, the same thing that you're looking at, accessory lobe, a circummarginated, you're looking at a bilobe placenta. Just be watchful that are there any vessels connecting the two areas? Am I looking at any trouble over there? Now, circumvallate placenta, infolding of the margins of the placenta sometimes can be associated with increased chances of placental abruption and folding over there. Various causes of antepartum bleeding. We're going to be more interested in placenta previa and abruptio, and I'm going to be just showing you a few things, what all you should be looking at. We know the bleeding is painless, the bleeding is causeless. You're looking at a placenta which is quite low down. That's already been spoken about, but the diagnostic on is the ultrasound. Now, we have a transabdominal probe, we have a transvaginal probe, and we can use the translabial or a transperineal probe. Every one of us has that probe, so do not worry what is this new probe that we're asking for now. You just have to be looking at a transabdominal probe, wear a glove, put in a little bit of jelly over there, put your transabdominal probe and deglove it over there. And your translabial probe, the convex sector transducer, the transabdominal probe is ready. So don't worry about that. And it gives you fantastic information. Sometimes you could be hesitant upon doing the transvaginal, should I be doing it or not, when the patient is bleeding, but you can comfortably do a translabial scan. We're looking at the placenta, a posterior placenta, which is coming down till the os and it's spanning across it. Always and always, rather than just labeling into complete, marginal, partial, always mention how much distance is it away from the os or is it traversing beyond the os, so that next time whenever you're doing it or somebody else is doing it, they can be sure. There you're looking at the placenta receding a little bit, posterior placenta C. You're looking at the placenta posterior one, that's the internal os, and we know it's more than 2 centimeters and you are comfortable. You could be looking at a placenta completely covering the internal os, partially covering it, placental edge. That classification has already been discussed upon when the cervix is dilated or it's a little farther away, but more than 2 centimeters or less than 2 centimeters. We come on to abruption, and it's basically a premature separation, we all are aware. We're looking at a normally implanted placenta, and it can be precipitated by various reasons. I'm not going into all those details. But yes, you need to be careful. You could either be looking at a retroplacental collection. You could be looking at a subchorionic bleed, little behind the placenta and some farther away. There could be concealed bleeding, or you could be looking at. If you see over here, and as Dr. Saul correctly mentioned, that the sensitivity is quite low. Now, what's the reason behind it? Because you could miss it in the acute phase because the blood is going to be isoechoic as compared to the placenta. Now, there's a little cheat code to it. What happens is, if you find that the placenta is abnormally thick and you're suspecting an abruptio, then you need to be carefully visualizing that area. Once the hematoma there's a resolution to it, it will be initially be hyperechoic and gradually become sonolucent. There you're looking at an abruptio over there. Initially, it could be as echogenic as the placenta. If it's behind the placenta, just be a little watchful. Various other types of things, a subchorial villus thrombosis, you could be looking at venous lakes, you could be looking at a hematoma. Just be watchful. All focal lesions, you do not need to worry. You just need to be carefully evaluating them. Placental hematoma. You're not looking at any blood vessels inside, but you see a subtle difference in the echo pattern in the placenta. A thickening of the placenta, and that's when you figure out there is something amiss. There is something called as a grayscale on the ultrasound or the grayscale maps. You can always make it a little more contrast here, and then you're going to find a little subtle difference. We're going to be telling you about these things in a little detail. Placenta accreta, we know abnormal attachment, chorionic villi invading abnormally. There could be a primary deficiency associated with placenta previa, and it's proportional to the number of prior cesarean sections. So you could be looking at normal placenta, accreta, increta, or percreta, depending on how much it is invaded. Now, why do we really need to be looking at? Because maternal morbidity and mortality can occur because of severe and sometimes life-threatening hemorrhage. The rates of maternal death increase, and patients with placenta accreta are more likely to require hysterectomy at the time of delivery. So we need to know forewarned is forearmed. Might be we would be doing a little bit more of preparation, but there is never harm for it because at least we are ready for any sort of collapse. You could be looking at features as early as the first trimester, but we usually tend to diagnose them and carefully watch out for in the second and the third trimester. Various risk factors, previous cesarean delivery, placenta previa are the commonest risk factors. Most important ultrasonographic association of placenta accreta spectrum in the second and third trimester is the presence of placenta previa seen in more than 80% of accreta. The grayscale abnormalities, which I'm going to show you plenty of pictures and videos as well, you could be looking at multiple vascular lacunae. You're going to be looking at the loss of normal hypoechoic zone between the placenta and myometrium. A decreased retroplacental myometrial thickness, less than a millimeter. Abnormalities of uterine serosa bladder interface and extension of the bladder into myometrium. We only think about this, not the others. Let's start thinking, and multiple vascular lacunae is one of the commonest and most sensitive grayscale abnormality. You could look in at color as well, turbulent lacunar blood flow, and you could look in at increased subplacental vascularity, gaps in the myometrial blood flow, and vessels bridging the placenta. Now there's a clear zone, that's the hypoechoic retroplacental space. There. That's why you're looking at, this is normal. But if you do not see any, that is abnormal. You're not looking at any clear zone. That's the normal one over there, but we know we're looking at things that are troubling. The normal dictum that I follow is, if you're looking at a previous cesarean scar, anterior placenta, which refuses to go up, you're definitely going to be looking at placenta accreta unless and until proved otherwise. Carefully see the clear zone over there. Then loss of the clear zone, that's not going to be visible, and it can be seen in about 70% of the cases. Then you're looking at myometrial thinning, less than a millimeter or almost undetectable, seen in 50% of affected cases. This is something which I've started doing, and plenty of us are doing it now with the linear probe, the same probe that you use for breast, thyroid, and small parts. You can look in for carefully the clear zone, looking for myometrial thinning with the linear probe, because in the third trimester, you'll be able to see that. Now, placental lacunae is something which is extremely important, and all of us have to start looking at it. It's the presence and the extent of lacunae within the placenta. And we have these 4 grades, the Finberg's criteria. Grade 0, when none of them is seen, 1+ when 1 to 3, smaller seen, 2+ when 4 to 6, larger or more irregular, and 3+ when it's seen.
Satyapriya, lost his connection or what?
Can't hear him.
Satyapriya, please see. Dr. Kuldeep Singh's connection is to be restored. Are you there, Dr. Saityapriya?
Saityapriya is not there.
So are you going to call him? Please call him and ask whether he is any problem for connecting.
I'll just check. He's accidentally left, I think. I can't see him.
Yeah, must have been disconnected. Saityapriya, can you hear me? Saityapriya? She's muted.
I'll call her.
Yeah, please call Dr. Pam, please call, no?
Yeah.
Because
just
my
wait.
phone is new or I cannot operate my phone.
I'll call her.
Pratibha?
Okay, yeah.
I'm just trying to see what's happened because
He's joining, madam. He's joining in 2 minutes.
Yeah, okay.
Yes, ma'am.
Accidentally thrown out of the net.
Ma'am.
Anyway, thank you everybody for your patient hearing, and still everybody is glued to the camera and screen and listening to the talks and the great deliberations by all the speakers, stalwarts. We are really fortunate to get know-how of all about placenta very well by the big people, with the stalwarts, well-read and well-educated. They really prepared their talks only for this webinar, and I'm really thankful. And on behalf of Foxy International Academic Exchange Committee, my co-coordinator, Dr. Pratibha Singh, who is the president-elect now of this committee, and she will be the torchbearer, and followed by Pam, who is the national coordinator-elect of our society, and we have been working so well seasoned, and Rajyog was one of our social service for during COVID, and we covered whole of the India only for the general practicing gynecologists. We've conducted all these webinars, and they were given very tremendous response from all over, and people are really delighted that we chose basic subjects like placenta, amniotic fluid, and normal labor, and they were discussed by the stalwarts from those the field of obstetrics and gynecology, and people were really happy. The motto was to give good knowledge or update to the general practicing gynecologists who from their OPD, they should be able to give the best treatments, and updates also they should get from such webinars. Thank you so much. Is Dr. Kuldeep is able to join? Saityapriya? Pratibha?
I'm calling him, madam. Actually, he's unable to.
Yeah, because a little bit of his talk is there still remaining. So, and he was also waiting for so long. So we should justify his presence and the remaining talk. Dr. Vishal Patil, thank you so much for joining, and Dr. Shilpa Ambire.
Thank you very much, madam.
Hello. Okay. No problem, sir. No problem. Thank you so much. Thank you so much. Okay, sir. Okay. Thank you. Bye. Good day. Good night. Dr. Kuldeep Jain just rang me up and told he is unable to join. So I think we should conclude the session, Dr. Pratibha Singh, for the vote of thanks and acknowledge the all the audience.
Let Dr. Vishal Patil just conclude the session. Dr. Vishal.
Yeah.
Hello.
Yes.
Hello.
Dr.
Yes.
Vishal Patil.
Yeah.
Okay. Thank you, madam. Actually, the lecturer, Dr. Kuldeep Singh, has just left. I want to thank him that for giving such a wonderful and dynamic academic piece lecture on sonography in relation with placenta. And the take-home message will be forewarned is forearmed, because everyone is very used to sonology. And in case of placenta previa or in placental abruption or accreta pacrita, in that cases, we must go ahead with the first trimester, second trimester, third trimester, early USG, so that we can diagnose all the accreta, increta, pacrita in time bound. And at the time of delivery, we can take care of all the complications, which are already nicely elaborated by our previous lecturers also. I also like to thank Dr. Varsha Baste madam, Dr. Pardeshi sir, Dr. Mane sir, and all MOCs and all chairpersons for giving me the opportunity for attending this session. Thank you, madam.
Thank you. Thank you. We are also obliged.
Thank you, Dr. Vishal. Okay, can I start? Vote of thanks, Dr.
Yes, please. Thank you, Dr. Gangadhar Sahu sir and Dr. Hemant Deshpande sir for staying so long and gracing the occasion. We are really blessed. Thank you. Over to you, Pratibha.
So good evening once again. And first of all, I would like to thank all the viewers for their valuable presence. And my sincere gratitude to our guests, Dr. Rajan Singh Pardesi sir, Dr. H.P. Patnaik sir, Dr. Ajay Mane, Dr. Sneha Bhuyar, and Dr. Charulata. Thanks for accepting our invitation and blessing us. And today we had a talk on all about placenta, which was really wonderful. And it was like a revision, right from embryology to recent advancement related to placenta. So it was really wonderful. And thanks to our all esteemed speakers, Dr. Gorak Mandukar, Dr. Hemant Deshpande sir, Dr. Gangadhar Sahu sir, Dr. Kuldeep Singh sir, although he could not finish his talk, but it was wonderful. Thank you so much for such excellent deliberation. And I also take this opportunity to thank all of our chairpersons, Dr. Dhananjay Patil, Dr. Rahul Vani, Dr. Santosh, Dr. Swarupa Iyer, Dr. Sandhya Saharan, Dr. Shilpa, and Dr. Vishal Patil for making all sessions so interactive and interesting. So thank you so much. And now I also want to thank all of my Master of Ceremony, Dr. Monica, and my co-coordinator, Dr. Shashibala Bhosledi, for a smooth coordination. And finally, many, many congratulations to Dr. Varsha Baste madam for successfully completing this series of very informative IAC webinars. So congratulations once again, and thank you so much. And once again, good night and goodbye and happy Navratri to all of you. Thank you. Thank you so much.
Thank you. Thank you, everybody. And Chabba Khair, thank you so much for staying. Hello.
Good night.
And I'm really obliged, and really, it was wonderful journey with all of you, and so many logged in and so many benefited also. Thank you so much. Shabba khair, fir milenge.
You are awesome,
Dhanyawad.
awesome, Varsha. You are just none to beat you. It's just perfect.
Just like you, I'm following you. Thank you, Pam. Thank you, Vishal. Thank you, Shilpa. Thank you, everybody.
Thank you.